Here we go. Dr. Brian DeBeer is a clinical research psychologist at the Waco Center of Excellence, specializing in suicide prevention research. A graduate of the University of Maryland, her research focuses on suicide prevention and identifying the risk factors for suicide. Please welcome Dr. DeBeer.
Thank you so much, Perry. Can people hear me on the microphone? Do I need to move it up? Oh, perfect, thanks. Is this better? Okay, great. Thank you so much, Perry. I'm so delighted to be here today talking with you all about my research within suicide prevention in veteran populations. I am a clinical research psychologist at the VA Vision 17 Center of Excellence for Research on Returning War Veterans. Dr. Meyer is one of my colleagues, and a lot of the research that I'm talking about today stems out of our collaboration on Project SERVE. So actually, Perry, great ordering of the presentation because it sets me up nicely to talk about my research. I also feel like Lieutenant Colonel Warner's presentation also gave you a really nice overview of kind of where are we at with mental health and the military. And so I'm going to be picking up from there and talking a little bit about my research. Again, this is the standard disclosure slide that we're all giving, that these are my own views and they don't reflect the policy of the VA. So we know that within this country, even more broadly than veteran populations, we're really having a crisis of suicide. Suicide is now the 9th leading cause of death within the United States. And we also know that 22 veterans die by suicide per day. So this is a very serious problem. And we really need to be creating efforts on all fronts to address this issue. And the VA has done this. One of my colleagues, Craig Bryan, one of my collaborators, was recently quoted in the New York Times as saying, "The VA has done more to prevent suicide than anyone in the history of the human race." We are working on this problem, and we are working very hard on it. And some tangible examples of what we have done are things like developing the Veterans Crisis Line, so veterans can call in when they're experiencing a suicidal crisis, be connected with care immediately. We have created these suicide prevention teams, which are embedded within each hospital system. These teams are trained in how to handle suicide crises, and they go out and train all staff in our suicide prevention efforts. We've developed empirically supported efforts for suicide prevention, things like safety planning. So if a veteran's experiencing a suicidal crisis, or even just experiencing suicidal ideation, a clinician can sit down with them and say, okay, so when you're getting into a crisis, what's going to be your plan? And this is an empirically supported method that we use. The VA has also developed a number of treatments to reduce mental health symptoms that also reduce suicidal ideation. These efforts are working. We are working very hard. However, we are still in the midst of a crisis. And so what we need to do is we need to think in very innovative ways about how to address this. We need to do things that we've never done before. We need to think about this differently. And that's what I try to do. And I try very hard. So I'm going to talk to you a little bit about how I'm thinking about this and how my research addresses this. So, what's behind this number? Why is this a crisis in veteran populations? What are the unique things about veteran populations that may make them more at risk? What do we know? Where are we at? Lieutenant Colonel Warner's presentation kind of gave you a good overview that the military has really expanded the services. You didn't hear what it was? I'll talk a little louder. Where are we at? What do we know? We really need to look differently at this problem. We need to examine it from different angles. We need to think about it differently than just something that's associated with mental health problems. How can we tackle this crisis differently? And how can we approach it from multiple angles? So we know that, as has been mentioned in previous talks, we know that particularly the veterans, the most recent veterans, have gone into these conflicts. They've gone on repeated deployments. And what happens when you go on repeated deployments that are very lengthy, the more likely you are to go on a deployment, more likely you are to experience combat exposure. We know that the more likely you are to experience combat exposure, the more likely you are to experience a variety of mental health problems. This is some of my work on Project Serve with Dr. Nathan Kimbrell, Dr. Eric Meyer, who just spoke. We know that this combat exposure raises risk for a variety of mental health symptoms, particularly PTSD and depression. We know that these mental health disorders are associated with increased risk of suicidal ideation in this population. There's conflicting evidence that combat exposure directly affects suicidal ideation and behavior. It's more likely that it goes through a pathway of you experience combat exposure, you develop mental health symptoms, you experience suicidal ideation. We also know that social support is a protective factor, as Dr. Meyer mentioned. I have done some research on this. And we know that that's particularly important for veteran populations because veterans may have difficulty reintegrating upon return from deployment. And many of them who experience these difficulties, likely because they're experiencing mental health symptoms, PTSD and depression, we know that when you experience those symptoms, oftentimes you become socially isolated. So I did some research within the context of Project Serve, and I wanted to understand the role of post-deployment social support. So specifically when people return from deployment, how is that affecting suicidal ideation within the context of mental health symptoms? And what we found from this research, this is a little, oh great, little pointer. So if you have low PTSD MDD symptoms, you're not experiencing much suicidal ideation. If you have, which is what we would expect. If you have high PTSD and MDD symptoms and high social support, you're experiencing much less suicidal ideation than those who have low social support. So if you have high social support and PTSD and MDD symptoms, you look similarly to people who have low symptoms. So this to me is fascinating that that social support can be that much of a buffer. So we know this role of social support is really important, but what are we doing about it? And the Military Veteran Peer Network is a great way to augment social support. But what are we doing in the VA? And the answer is not much. We're really not. We don't have many services that address this issue of social support. So let me recap a little bit. MDD and PTSD raise suicide risk. We know that particularly with these conflicts, people are more likely to experience combat exposure, more likely to experience PTSD, MDD. And we do have treatments for MDD and PTSD that reduce suicide, but they don't work for everyone. So we really need fresh ways of examining this issue in order to stem this crisis. So right now we're focusing on reducing MDD and PTSD symptoms. We're not focusing on why social support is an issue, and we're not focusing on whether social support can be augmented as a suicide prevention tool. So why would social support be a particular issue in veteran populations? Well, when people discharge from the military, oftentimes they leave established support systems. And they move far away, they don't keep in touch with people. And so, many people develop new social support systems, but some people don't. And so why do some people continue to develop these great social support networks that support them, but other people don't? If we can understand this problem and how to change it, it might be the key to preventing suicide. So we know that social support predicts suicidal ideation and behavior. That's my research that I talked about. But there's an entirely separate literature, separate from the suicide literature, saying that there's this factor that I'm going to talk a little bit about in a minute called social cognition that predicts your level of social support that you have. The higher your levels of social cognition, the more support you have. So can we take these two separate lines of literature and merge them in order to understand more about suicide and how to prevent it? So what is social cognition? Social cognition is something that you use every day without knowing it. These are the basic processes of social interaction that underlie all social behavior. They're necessary for intact social functioning, and difficulty with social cognition predicts difficulties with social support and social functioning. So what am I talking about specifically? So these are some of the factors that comprise social cognition. Emotion perception. Are you able to accurately read emotion on other people's faces? This is an example of one of the tasks we use. We present different faces, and then people attribute the emotion experienced. Social perception. Are you able to gather and interpret social cues? So we have them watch videos, and they have to describe what is the social situation going on. Theory of mind, which is this funny, fancy way of saying, can you understand what someone else is thinking? So we have people watch video vignettes, and they have to describe what is going on in that situation. And attributional bias, which is the manner in which people explain social events that occur in their lives. So for example, if someone jumps in front of the line at the grocery store and says, I'm in a rush, what do you think the real reason is that they jumped in front of you? So another factor that's very important here is social competence. So social competence is a set of social skills that include verbal, nonverbal, and cognitive behaviors that are necessary for interpersonal interaction. So I'm going to talk a little bit today about my research. This is one of the first places that I'm presenting this research. We are in the very initial stages of analysis on this project. This project is called Project Serve OASIS because it grew out of the research on Project Serve. OASIS stands for Observation and Assessment of Social Interaction and Suicide. So we examined social cognition as a risk factor for suicidal ideation and behavior in veterans with PTSD. We had 100 participants, 50 with prior suicide attempt, 50 without, and they completed measures of current suicidal thoughts, history of suicidal behaviors, social cognition, social support, and social functioning. And so one of the questions we had was, is social cognition disrupted in PTSD? Because there's very little literature on that. What we are finding is that, yes, there are disruptions in social cognition in individuals with PTSD. Likely because when someone experiences PTSD, they're constantly attuned to threat. They're looking for threat all the time, and they're not looking for the social cues. That's a problem. What we're finding in this research is that social cognition is predicting social competence, so how well you're interacting socially, and both of those things are predicting suicidal ideation. So what we're finding out from this research is that social cognition may be this new factor, we haven't looked at it before, that could be predictive of suicidal ideation and behavior. And it is disrupted in those with PTSD. So we're learning about this. So this research is at its very beginning stages. So what are our future directions? So how can we tackle this crisis differently? What can we do differently that we're not doing right now? We need more research on social cognition to determine whether these measures can accurately predict people who are at high risk for suicide. Because if we can know that, that would help us identify people so that we can intervene with them earlier. We need to develop social cognitive interventions to assist those in boosting social support to see if that prevents suicide. There are social cognitive treatments that are developed. Obviously, these are skills. Skills can be taught. And there are social cognitive treatments just in order to boost social functioning. So can we take these interventions, modify them for suicide prevention, and see if they have good outcomes? So, just some take-home points about what I talked about today. So my research is in its beginning stages, so unfortunately, it's not as, I don't have as many straightforward messages about what can you do today about this. What's behind this number? Why is this a crisis? Well, we know that our veterans have had repeated combat exposure. That's increasing symptoms. That's increasing suicide risk. We have treatments, but they don't work for everyone. We know that social support buffers this risk, and we know that there are unique social support issues to military and veteran populations, like leaving established social support systems upon discharge, PTSD and MDD symptoms that interfere with social functioning. We need to take a different look at this problem. Taking a different look, social cognition may be a key mechanism here that we haven't looked at before. How can we tackle this crisis differently? We need more research to see if we can use social cognition to identify those at risk. And we need to approach this from multiple angles. So these treatments for MDD and PTSD are great. We need to keep doing them. We need to keep doing all of the interventions that we're doing within the VA. But we need to develop social cognitive treatments to see if they boost social support and prevent suicide. And we need more efforts like the Military Veteran Peer Network that focuses on social support in order to assist veterans. Thank you so much. It was really great to be here.
And Dr. DeBeer, thank you very much.
Thank you, Perry.
Thanks for staying on time.
Sure.
So that's even better. So we'll try to get caught up here.